before ma'am starts, I think I'll hand over mic to Dr. Kanaram. He has joined. So now Dr. Kanaram will start further proceeding. He will introduce Dr. Manisha, and Dr. Manisha will continue the program.
Sure, sure.
Over to you, sir.
Okay, thank you, Dr. Javed. Sorry for the
Dr.
delay
Kanaram.
problem in the network. So, Dr. Manisha Jana is the professor of Department of Radiology and Intervention Radiology. And you will see very few centers in the world will have the dedicated or exclusive pediatric person that reporting only pediatric chest imaging. That is the Dr. Manisha Jana hai. So we are very fortunate to have the in our center exclusive the radiologist that report the pediatric chest imaging. So she will discuss in the many CT scan today. But we are very see the other imagings also like ultrasounds for pediatrics, MRI also. So I request Dr. Manisha to start the this session.
Thank you, sir. Thank you, Dr. Javed. Thank you, Dr. Kanaram, for the kind intro. I'll just start with the presentation. So, whenever we are talking about CT for from a pediatrician's perspective, it is a bit different from like how we are taught CTs. So I won't go more into the technicalities, more into the practical aspects, like what matters to you. Okay, some things you will have to leave to the radiologist to decide, and some things you have to take a call upon. Okay, so today we'll be mainly focusing on the CT. So we know in CT these two terms are very commonly used, that is hypodense, hyperdense, attenuation. So CT is just different degrees of black, white, and gray. And depending on whether whether there is more of a black or hypoattenuation, or more of a white or gray attenuation or white attenuation, we classify or try to classify the diseases into some categories. So here in this slide, I will just, like, this is an oversimplification, that CT is kind of this black and white palette, and we have some diseases which will go to the left hand of the spectrum, presenting as being more black or hypoattenuation, like emphysema or cysts. And this, on the other hand, we are seeing more white or denser things like mass, consolidation, ground glass opacity. So broadly, these two types of things we see on a lung window. And I'll be coming to the mediastinal window later. So about this window thing, the CT acquisition is a single acquisition, and after that the raw data of the CT scan images, they go through some filters. So it depends on through which filter the data is going. When it goes through a soft tissue filters or in that image we see the mediastinal structures, the vessels. When it goes through a high resolution, relatively higher resolution filter, we get a sharper image where we see the lungs. So high resolution CT is, in today's era, all the CT scanners, they have a volumetric acquisition, that is the one part of the body is scanned as a whole volume, and after that the data is reconstructed in multiple small sections. And during that reconstruction, HRCT is almost always done, even if not written on the requisition. So HRCT will be done in all kind of CT scans, MDCT scans that are acquired now. The thing that you have to decide is whether you want a contrast scan or a non-contrast scan. Irrespective of non-contrast or contrast, HRCT reconstruction will be done in all, and they will be similar. The difference will be in the visualization of the mediastinal structures, the vessels, the nerves, the nodes, and other soft tissue structures. Okay, so Coming to the functional unit of the lungs, we know about the secondary pulmonary lobule. This is a polygonal structure, and it touches the visceral pleura. And we know that at the center of it lies the bronchiole and the pulmonary artery branch. And the veins and lymphatics actually run both in the center as well as the periphery, whereas the veins lie at the periphery of the pulmonary lobule. Why why we are talking about this thing? Because if we know this anatomy, then it will be easier to understand why we use these terms like centrilobular nodules, like perilymphatic nodules. So that will be discussed later. Now, we are talking about the right hand of that figure when we see increased attenuation within the lungs. So lungs, they are filled with air. So that's why it is usually black. And the little bit of density that we see in normal lung is because of the vessels, the vascularity within the lung. That's why whenever there is a reduction of the vascularity, like in hypoplasia, like in chronic pulmonary thromboembolism, the lungs become even more lucent or more black. Okay. So the causes of increased attenuation of the conditions which result in appearance of increased attenuation are these things. So I'll be describing about these terms one by one. So what is a ground glass opacity? A ground glass opacity means this is normal lung. We can see the vessels scattered since these are axial scans. So they are cut in cross sections, especially, usually. So whenever there is increased attenuation, but that attenuation does not obscure the vessels. You can see the pulmonary arteries and veins coursing through that lesion. So this is called ground glass opacity. Now this can result from any alveolar process, maybe due to exudates, alveolitis, or can be fluid, can be blood, anything. And an extension of this thing, when this thing becomes much more dense, that gives rise to consolidation when it starts to obscure the vessels surrounding. So you can just imagine if this density becomes a little more, it will become consolidation. Now, ground glass opacity, once we have seen, those we have to look at the distribution. So it can be a diffuse ground glass opacity all through the lungs. It can be located at the central with peripheral sparing, or it can be like here what we are seeing as perilobular and peribronchovascular. You can see this very geographic kind of appearance, ground glass opacification peripherally, and this is what is known as atoll sign. Atoll is a group of small islands covering a part of the sea. So there is peripheral consolidation and central ground glass opacity. So these features are suggestive of organizing pneumonia or OP. So the causes of organizing pneumonia might be a lot. They can be seen in drug-induced pneumonias. They can be seen in various types of ILDs in children as well, mainly connective tissue disease related ILDs. Now, regarding the distribution of the ground glass opacity. So if we see here, there is ground glass opacity. Of course, this area is showing ground glass opacity because you can see the vessels coursing through it. But just by the side, we can see maybe a few secondary pulmonary lobules, which are appearing much more black. So those are the areas of air trapping. You can see the central vessel going through it. So whenever there is GGO and air trapping, both living side by side, then we have to think about hypersensitivity pneumonitis. Like in diffuse alveolar hemorrhage, you see typical very uniform involvement of all the lung fields with a little bit of sparing of the peripheral part, exactly subpleural part, the costophrenic angles and the epices. And this is how diffuse alveolar hemorrhage looks like. Sometimes In chronic DAH, there might be smooth septal thickening superimposed on this as well. No, that was ground glass opacity. Now this is consolidation. Why this is consolidation? So there is increased density and it has obscured the vessels. We cannot see any vessels through this, right? And moreover, here we are seeing air bronchogram, branching air bronchogram. Now consolidation is not synonymous with infective pneumonia. I mean, consolidation is the radiological appearance of bacterial pneumonia, but it is not equal to that. So there are other causes of consolidation as well. Like if there is a passive collapse, at the beginning it will look like this. If there is a pulmonary infarct, it will again look like this. Okay. When the consolidations are small, they can appear like this, variable kind of shape and outline, and the vessels are not recognized. So depending on whether it is unilateral or bilateral or multifocal, the causes of consolidation vary. Unilateral lobar consolidation most commonly is caused by bacterial pneumonia, typical appearance, and pulmonary infarct is also one of that appearance. If there are multifocal or bilateral consolidations, we'll have to think about something else other than typical bacterial pneumonia, like viral pneumonia or even fungal or even non-infectious causes. So here are appearing some examples of multifocal consolidation. In the upper two panels, if we see, there are some consolidations, some nodules where, and there is ground glass opacity. And what we see is typical lobar consolidation with air bronchogram and cavitation inside. So this is more in keeping with an infective pathology. Whereas if we look at these images, here what we see is peripheral bronchocentric kind of consolidation. They are all plural based, symmetrically distributed bilaterally, and this is the appearance of organizing pneumonia. And the causes may be variable. Similarly, we can see this Étole sign or organizing pneumonia. Now, round pneumonia typically the term is used when they are much more well defined and sometimes they may be mistaken as a mass. We can see a combination of consolidation and nodules with cavitation, and sometimes the nodules may cavitate to form thin-walled cysts as well. This kind of picture usually seen in bloodborne infection when you see consolidation and peripherally placed nodules. So whenever we are seeing the peripherally placed nodules, it means that the nodules, they have come from the bloodstream and they have lodged at the periphery, at the distalmost end via bloodstream dissemination. And they can cavitate and develop nematocele as well. To the contrary, bronchopneumonia pattern, this is usually around the bronchi, peribronchovascular bundle, multiple bilateral. This bronchopneumonia pattern is more common in viral pneumonia. However, some bacterial pneumonia can also show this kind of appearance. Atypical pneumonia like mycoplasma can also give rise to this appearance. Now, one important thing is when to call consolidation, when to call collapse. If there is volume loss associated, that means if we are seeing that there is fissural shift or mediastinal shift, then it is collapse. So the importance between differentiation is that a consolidation is usually, it implies an active inflammation or exudates within the alveoli, whereas collapse may be secondary or passive, like it can imply chronicity if it's a fibrotic kind of thing. It can imply passive collapse when we are dealing with a large pleural effusion, right? So this is how, like this is an in this radiograph, we can see that there is a lobar pneumonia of the right upper lobe anterior segment, which is which is being limited by the minor fissure. There is no volume loss. However, if there is a chronicity and this fissure gets pulled upwards, like we are seeing here. So it is called collapse, and it implies chronicity. Now, about bacterial pneumonia and about other causes of infectious causes of consolidation. So we all know about necrotizing pneumonia. So necrotizing pneumonia usually is a type of lobar pneumonia, big in size, and the center part of it is it gets necrosed and sloughed off. Subsequently, it forms a cavity, and thereafter, these are all serial radiograph of the same kid. Whenever there is this sloughing out and expectoration of that parenchyma out, we can see that there is a shift of the fissure. It is being drawn towards it. So there is some amount of healing, but there is a cavity formation after that. This is actually different from a lung abscess. This is actually in the process of healing. So this is a sloughed out lung parenchyma which has gone, and only at the periphery this part of parenchyma is left. If we look at this thing, this is the typical evolution of a bacterial necrotizing pneumonia. Usually what we see is in cases of staph or pseudomonas or klebsiella or even E. coli sepsis. Whereas if we see this kind of bacterial, this kind of lobar consolidation, see this is also lobar consolidation. We can see this is in the left upper lobe. There is a lobar consolidation, but what is more important is that within that area, there is a very early onset of this mottled areas of air and low attenuation. So it is not exactly sloughed out, not fully air, neither it is fully consolidation. And the consolidation itself is enhancing quite less. Normally, the consolidation area, it has intact blood supply. So it will enhance well. It will be very much hyperdense. But whenever we can see these areas of low density, that means that the blood supply is getting compromised, and that part is on the verge of getting necrosed and getting devitalized. So if we see this kind of appearance, which is known as bird nest sign, this is very much indicative of angioinvasive fungal infection like mucormycosis. Typically, angioinvasive aspergillosis does not give this kind of appearance. This kind of lobar consolidation, big area with adjacent vascular invasion, we can see the vessels subtending to this area, they are also non-visualized. So it is the angio invasion which is giving rise to this very early onset of cavitation, and this is known as typically called bird's nest sign because of this dirty kind of area inside this. So this is quite suggestive of mucormycosis. Now, coming to the pneumonia, there are the complications of pneumonia can be pleural complications can be pleural effusion or empyema. So, how to differentiate between the two? If we see a fluid, low attenuation fluid without any clear wall to it, the pleura that is adjacent to the chest wall is not enhancing. To the contrary, if we see this image, the pleura that is adjacent to the chest wall, that is enhancing and thick. And there is another layer also which is also enhancing. So this is called split pleura sign. This is quite indicative of a very inflamed, chronically inflamed or badly inflamed pleura and suggestive of empyema. This is free pleural effusion, this is empyema. Hydropneumothorax, we know that usually we'll be seeing a air fluid level when we are seeing on axial scan. And how do we know that this part of the air, it is not within the lung, it is within the pleural cavity? It is the mass effect, the pressure effect that it is causing to the lung. We can see the collapsed lung, which is being pushed towards the medial side, and subsequently Even the left main bronchus is also getting stretched. Now, those are bacterial pneumonia complications. If we are talking about viral pneumonia complications, PIBO is one entity which we should keep in mind. Usually, the findings of PIBO are diffuse and consists of mainly bronchiolitis obliterans, means the end that end part of the air passage, it is getting obliterated. So there is during inspiration air will come in, but during expiration it cannot go out. So that is why we get this kind of patchy areas in the shape of a segment or lobule, which are getting trapped air, or air trapping is developing. So this is how air trapping would look like. And they can also have some peribronchial thickening or bronchiectasis or small fibrotic areas. Now, so these were in relation to GGO and consolidation. Next, white pattern is called crazy paving. So crazy paving is simply like once you have that mosaic kind of floor or different kind of attenuation closely spaced side by side. So this is ground glass opacity plus septal thickening. So this is what is known as crazy paving. The causes may be many. It can be PAP or pulmonary alveolar proteinosis. Again, the causes of PAP is numerous. It can be diffuse alveolar hemorrhage. These two can be differentiated by BAL. There can be other underlying disorders like surfactant deficiency disorder, dysfunction disorders. Storage disorders are also one cause of this pattern. Now, if we remove the GGO pattern from crazy paving, what remains is interlobular septal thickening. So septal thickening, we have seen the secondary pulmonary lobule. So when the outline of the septa is being very much demarcated, see, so this is known as septal thickening. If it is smooth, it can be because venous congestion in pulmonary edema or lymphatic congestion in lymphatic obstruction, say in mediastinal fibrosis, or any mass that is causing lymphatic drainage block or lymphangiectasia. If the septal thickening is not in the shape of this polygon type, rather it is along the bronchus and the bronchovascular bundle in the axial interstitium, or so that is this appearance, and it is kind of nodular, very not this kind of smooth. This kind of feature is seen in cases of sarcoidosis in children. In adults, this kind of appearance is seen in lymphangitis carcinomatosa, which is much, which we are not talking about in kids. In if the septal thickening is there, but it is very haphazard, zigzag, irregular manner, it can be seen in cases of fibrotic ILDs. So about the white part of that graph, what remains is nodules and masses. So nodules again, we are going back to the that image of a secondary pulmonary lobule. So when this is the central interstitium, and this is the this is central interstitium, and this is the interlobular septa. So whenever we are having nodules which are located in the center of the acini, these are centrilobular nodules. Sometimes the centrilobular nodules, they just fill the distal part of the airway. So this is how the tree in bud appearance looks like. Whenever we have nodules along the interstitium, maybe peribronchovascular interstitium, or along the border of the uh, lobule, this is perilymphatic nodule. An example of a perilymphatic nodule is this in sarcoidosis. So why we are saying that? So we will have to see through on this, see that if the wall of the bronchus is very much irregular and thickened, this one, plus there are nodules on the pleural surface as well. So this is perilymphatic nodule. Random nodule is, it can be located anywhere without any specific distribution. That was perilymphatic nodule. This is centrilobular nodule. So to identify centrilobular nodule, we have to look at the pleural surface. If there is anything, if there is nothing in the pleural, if there is nothing on the pleural surface, then it becomes centrilobular. So these two are centrilobular nodules. But this one is different from this one. Here we see very uniformly groundless, ill-defined kind of nodules where you cannot exactly draw the boundary of a nodule and very low attenuation. So this is the typical appearance of acute hypersensitivity pneumonitis. Whereas in contrast, these nodules, you can draw the outline of the nodules very well. And at some places, you can see what was I was showing us tree in bud. So this is a tree in bud. So this is well-defined, relatively well-defined centrilobular nodule with tree in bud. At some places, they are coalescing. So this is typical of endobronchial spread of infection or even bronchiolitis of other causes. So this is mainly active exudate formation within the bronchi and clogging them. So these are the two different types of centrilobular nodules. So there, this is a graph of different causes of branching and non-branching kind of uh, centrilobular nodules. Coming to the random nodules, like here, they are everywhere. I mean, they're along the septa, along the pleural surface, within the lobule as well. So, typical example is miliary tuberculosis. Like here, we can see this is typically how we see miliary nodules. See, the nodules are very clearly defined. You can see the margins, they're very sharp, very well defined, very tiny nodules, millet shaped. So this is quite suggestive of miliary infection like tuberculosis in our scenario. Talking about a few specific features like nodules with surrounding ground glass opacity or the halo sign. We all know that this sign is described in relation to angioinvasive fungal infection, especially aspergillus infection. But there are other causes to it like GPA or granulomatosis with polyangiitis or earlier known as Wegener's granulomatosis. They can also give this kind of appearance. However, in like a febrile neutropenic kid with this kind of appearance, we should strongly suggest that there is angioinvasive fungal infection. Now, focus on this nodule and subsequently it may happen that the nodule may appear like this. So this is a sign of improving immunity and response that there is a air crescent being formed. So this is not worsening, this is actually betterment. So this was in brief the increased attenuation of the white part. About the decreased attenuation or the black arrow. So the things that can present with decreased attenuation is uh, cyst, cavity, emphysema, hyperinflation, and bronchiectasis and honeycombing. So what are cysts? Cysts are very well defined. When we can see the wall of it, the wall may be very thin, very, very thin, not measurable, but they will have a definite wall. So that is cyst. And the causes of cysts in children, it can be post-infective, uh, it can be end stage of ILD, but there can be other cystic causes of ILD like LCH, lymphangioliomatosis, and LIP. Now, when the cysts are layered, multiple layer of cysts, they're stacked one on top of the other. We can see one layer, two layers. So they are stacked on one another and they have shared walls. This is known as honeycombing. Typically, this is seen in cases of fibrotic interstitial lung disease. And bronchiectasis, when seen in an area of fibrosis with volume loss, it is known as traction bronchiectasis. Now, these two terms are many times it creates confusion, mosaic attenuation and air trapping. What do they mean? So, whenever we are not doing any expiratory CT, which is very difficult to obtained in children until unless there is a dedicated anesthesiologist who is ready to give apnea. So in that case, routine scan, we call this mosaic attenuation. Now the mosaic attenuation can be either because of that the white area is abnormal or ground glass and this black area is normal. That is one possibility. And the second possibility is the white area is normal and the black area is abnormal. In that case, it is because of air trapping. But the term air trapping should ideally be used in expiratory scan only, because in expiratory scan only you can prove that yes, this area is getting accentuated, it is remaining much more black. So then it is known as air trapping. And another pointer towards calling some area black because of air trapping is that if we see peribronchial thickening or bronchiectasis in the black area, that means that the bronchi or the airway in that side is inflamed. The wall is thickened. So that's why when during inspiration air can go in, but during expiration it is getting shut down and there is air trapping. So this is an indirect pointer to it. And whenever we see that the vessel density is less in a black area, then the black area is abnormal. Now about low attenuation, there can be CPAM can be one cause of it. Like there is a big cyst, thin walled, but there are multiple other cystic lesions which are in the vicinity as well. So this entire area is abnormal. This is the appearance of a congenital pulmonary airway malformation or CPAM, and moreover it is causing a mass effect. Another cause of low attenuation is like thin walled cyst, but if we see this multiple scattered in multiple lobes, then we have to keep in our DD nematocele as well and look for serial radiographs. Now, if we see a big air-filled thing on the left hemithorax, the confusion remains whether it is hydropneumothorax, loculated hydropneumothorax, or it can even be a big infected nematocele, big infected bulla. In such big lesions, it is very difficult to identify what it is. What we have to do is that you have to check whether the underlying lung is collapsed medially. That will point towards it being a pleural pathology. Now let's see a few cases. Like this is a 2-month-old infant who had persistent tachypnea. This is the CT topogram, that's why the quality is not that good. But for a 2-month-old boy, we can see that the lungs are very big. Usually in a supine position, 2-month-old baby, we are not supposed to see this much of big lungs. So there is some hyperinflation, that's what we can say. But when we did a CT, what we saw is that the central part of ground glass opacity, which is affecting the paramediastinal location, the lingula, the right middle lobe, whereas the distal part is appearing lucent. So there is central GGO and peripheral hyperlucency. That is actually it happens because of air trapping. So this picture with the typical age group is quite suggestive of NEHI or neuroendocrine cell hyperplasia of infancy. So in real life, in very few occasions, you have this typical telltale signs. But when you see this kind of typical imaging picture with this typical clinical picture, you can give this possibility of NEHI, which is usually a good condition which tends to improve. Now talking about diffuse lung diseases, again the simple thing, not simple, I mean the thing is that you have to decide whether it is more black or more white, and then you have to just pattern wise divide them into some categories, like whether it is GGO, whether it is consolidation, crazy paving, cysts or nodules, like these things. So let's look at this boy who is 10-year-old boy, and what we are seeing here, the pattern is ground glass opacity because vessels can be seen, but there is septal thickening as well. We can see typical crazy paving appearance. Is there any zonal predominance, any lobar predominance? No. So both the lungs from top to bottom is affected. There is crazy paving appearance. So this is crazy paving appearance, and the differentials will be a lot many. It can be pulmonary alveolar proteinosis, primary, or it can be because of surfactant disorders. It can be because of pneumocystis pneumonia, can be because of diffuse alveolar hemorrhage, and other causes. In this child, what we had is that this diffuse crazy paving pattern, and the child had hepatosplenomegaly, and this child turned out to be actually a known case of Gaucher's with lung involvement. So storage disorders should also be kept in mind when we see this kind of pattern along with organomegaly. Now, PAP in childhood is not a single disease entity. It has got a uh, lot of causes of it, being autoimmune, surfactant protein metabolism defect, other genetic causes, and metabolic and storage disorders, and even immunodeficiencies. Coming to this appearance, so what is the pattern? This is more towards the white, and this pattern is consolidation because vessels are obscured. Now, what is the distribution? It is more centrally located, more in the perihilar location with a little bit of sparing of the periphery. There is no ground glass opacification, pretty dense consolidation, and sparing of the central and peripheral part. Now, why I'm showing the mediastinal window is that if we look carefully, that there is there are some areas of very low attenuation here, and putting on a cursor on these, measuring the attenuation value will help to identify whether they are fat attenuation or not. If they are fat attenuation, then we are dealing with a lipoid pneumonia, which can be exogenous or endogenous lipoid pneumonia. But when it is this much symmetric bilaterally, mostly it is exogenous lipoid pneumonia. We need to take history of any exogenous installation of oil or paraffin anywhere. So and the onset of the disease is also important. See, this is such a small baby having this kind of appearance. So you have to think about lipoid pneumonia. And another disease entity also we should think in this kind of appearance, that is lentil hypersensitivity, which has been shown by Cabra sir here only. And lentil antigen positivity was detected. And in that lentil hypersensitivity also, typical weaning history with forceful dal feeding, and CT appearance of very dense consolidations. These are the imaging findings. Now, coming to fibrotic appearance in a diffuse lung disease. In fibrotic appearance, what we see is that they are much less common. In smaller kids, they are even less common. What we see in the second decade, usually we start getting fibrotic ILDs. They can be either associated with connective tissue disorders, or can be associated with sarcoidosis or hypersensitivity pneumonitis. Like this girl was a known SLE child and had this typical peripheral honeycombing and ground glass opacity. Whereas fibrotic hypersensitivity pneumonitis, we have seen kids of like even 9 or 10 years old getting this bad fibrotic lung with traction bronchiectasis, axial interstitial fibrosis, and this pectus careatum deformity. So this appearance um, usually corresponded with a history of pigeon dropping exposure and avian antigen positivity. Now, coming to the airway diseases, when we are talking about airway, so bronchiectasis is one thing which we can. There are subjective ways of telling and objective ways also. Signature appearance, we all know, when the airway adjacent to a vessel becomes bigger than the vessel. So this is how the appearance of a signet ring looks like. And bronchial arterial ratio, that is BAR, in small children, usually even if they are equal, that is taken as abnormal. And also see that whenever the airway is inflamed in the vicinity, the lung is black. That is because air trapping is happening. So causes of bronchiectasis can be variable. If it is localized at one place, there can be different causes. There can be local cause. Typically, we see asthmatic children, they are having bronchiectasis in the location of the middle lobe and lingula. And if there is diffuse bronchiectasis, so there we can somehow guess the cause of bronchiectasis. If there is a central predominance, it is mostly seen in ABPA. If it is upper lobar predominance, cystic fibrosis, TB, sarcoid, these things have to be kept in mind. Now, cystic bronchiectasis, when the bronchiectasis, the bronchi become very big, like a cyst, and they can they can behave like cavities also. Secondary infection, impaction, and colonization, everything can happen. So, primary ciliary dyskinesia is one cause of diffuse bronchiectasis. Whenever we are seeing airway involvement and recurrent infection and bronchiectasis, predominantly in the lower part where the mucociliary clearance movement matters most. So the upper way there is a gravity dependent drainage, whereas in the lower lobes it is dependent on the mucociliary movement. So in such situation, we should think about primary ciliary dyskinesia as a possibility. Cystic fibrosis typically have an upper lobar predominance, and we see this big bronchocells within the within the cavities, the cystic bronchiectasis areas. Sometimes cystic fibrosis and ABPA, they can coexist, and it may be difficult to identify the cause. So there is this sign called high attenuation mucus that is described. If this content within the bronchosil is very high attenuation, then it is called high attenuation mucus, which is quite suggestive of ABPA. Here is another appearance of cystic fibrosis, how it looks like. We can see this signet ring sign, bronchial wall thickening, bronchial dilatation. And wherever the bronchi are dilated, that segment is showing hyperinflation. There will be peribronchial thickening, there will be atelectasis as well. All these are features of cystic fibrosis. Now, a few cases, I have around 10-15 minutes left. I'll quickly run through a few cases. So this is a small boy with respiratory distress. So X-ray we cannot do without it. So that is the commonest investigation that we are going to get. This is the radiograph of a 2-year-old kid. What we see is a small volume right-sided hemithorax. So it seems that there is no lung at all on this side. And that's why the mediastinum has been shifted to the right side. The heart is also not visible. That is because extreme mediastinal shift. Now, if this is the picture from the beginning, since birth, then pulmonary agenesis becomes the possibility. If the same appearance is seen in an older child, we would be thinking about a foreign body. So this was a CT. I am just showing the relevant sections. So this is the trachea. Subsequently, a little lower down, we can see the trachea is becoming roundish like an O. Now this is abnormal. This happens only when the posterior wall of the trachea is also surrounded by a cartilaginous ring. Normally, it is membranous, that's why it is flattened, the posterior wall. So here the trachea is narrowed and becoming round. So we can see the narrowing over here. And on the coronal reformated MINIP image, we can see that the narrowing of the trachea just at the region of the carina, and there is no right main bronchus. So there is congenital tracheal cartilaginous ring with pulmonary agenesis, and there is a tracheal diverticulum. So whenever we are talking about congenital anomalies, there may be multiple abnormalities which may coexist in a single child. So visualization of the viewing the sections in all windows in all possible reformats is very important, so as we don't miss out anything. So again, the similar appearance of the round and narrow shape. So this is tracheal cartilaginous congenital ring. Similar appearance in an older kid, and complete opaque right hemithorax with ipsilateral shift. Now, foreign body is definitely a consideration, and when we see that there is a bronchial cutoff, then masses like carcinoid or IMFT will also be in our consideration. So, in these cases, CECT or preferably CT angio should be done because carcinoids enhance a lot in arterial phase. So in this, what we see, this is the arch of aorta, and mediastinum has been completely shifted to the right side. This is the main pulmonary artery, left pulmonary artery, and right pulmonary artery. So pulmonary artery to begin with is good. It is not hypoplasia. Definitely, it is not agenesis. And subsequently, we can see that this is the right main bronchus, and there is some soft tissue which is projecting inside. We go a little lower, we can see this entire soft tissue filling here, and that is causing complete collapse of the right lung. So this is the right lung collapsed, right lung at the periphery, and this central part is the mass. Now in this context, I would like to show you one image. This is the ultrasound. So I personally prefer doing ultrasound whenever possible because that gives you clarity in a lot more situations, like whether it is a mass or thymus, whether it is a cyst or a solid. And in this case, especially if we see that the distinction between the mass centrally and the consolidation peripherally, it is so stark, so prominent, which was not that much evident even on CT. So so whenever possible, we use our judgment to give it a sort of ultrasound to so that we can tailor our next investigation better. Now this is the coronal reformated mini image which shows this bronchial cutoff of the right main bronchus, and that is this was a carcinoid in this child. So I had to rush through a little bit at the lower part so that I don't exceed the time given. I hope you liked it. Thank you.
Okay. Thank you, ma'am, for the excellent presentation. So before going to the questions from audience, I have the few questions. So one questions we frequently face the one problem that many patients are referred from outside and they already at the CT. So when you go to with the to your side, you say there is a poor quality CT. We need the NCT, but we need the CCTs by the NCCT. So what is your message for the, our this audience? When to order the CCT and when to the NCCT, one thing, and second to how to ensure that the CT quality is good. So what should write on the requisition that CT is the good quality?
Okay, so first thing that CT mostly except from the very peripheral areas, mostly there is multi-detector CT everywhere in the center. So the slice of the CT scanner does not really matter beyond like 16 slice. It doesn't matter if you're doing in a 64 slice scanner or a 256 slice scanner, that is not really going to make a lot of difference in diagnosis. What is going to make difference is a good breath hold so that there is no motion artifact, and how we are doing it, like do we need to do a CT contrast scan or non-contrast scan. For all practical purposes, if we are dealing with a follow-up case of ILD or a known malignancy which we want to look for pulmonary mets, in those two conditions NCCT is enough. Rest all like suspected infection, suspected masses, CCT is to be done. And HRCT, you don't need to write separately. Usually HRCT reconstruction is done in all CCT as well as NCCT. That part is the same. Still, if you have any doubt that whether they will get HRCT sections or not, you can write CCT with HRCT reconstruction. That will be enough. And what was the second question? Sorry.
To ensure the quality good.
Okay.
How to ensure the
To
quality?
ensure the quality is Good breath hold is one thing. So if uh, whenever possible, whenever required, uh, proper sedation or immobilization should be done. But whenever that is not possible, we should try a fast scanner. In such situation, a fast scanner would help. Like the higher generation cities, higher slice cities, they can acquire the scan in like like even within 1 second. So in that situation, a higher number of scan sections, that like 256 slice scanner, that will be helpful.
Okay,
And regarding how we see them on the films, that also depends on how the printer is and how the printing has been done. Whenever possible, the data viewing on the console is always best, if possible.
Mm. There are some questions. One is the how to differentiate nematocysts and bulla in the CT scan.
Uh, mm, Nematocele usually have a perceivable wall, whereas the wall of bulla or emphysema, they are very thin, barely perceivable. And the bulla, typically they are in the subpleural location, and you have this background emphysematous changes. Those are the things. Otherwise, and for nematocysts, you have this typical evolution from a consolidation to thin walled cysts.
One question regarding this CT angio. So frequently you talk about this arterial phase, venous phase. So how to identify them and what is the importance of them?
Okay, so to identify, we'll just have to keep our eyes on the aorta. If the aorta is very bright and we are not seeing contrast on the uh, on the superior vena cava or the venous side, so that is the mm, arterial phase. And venous phase is when you see the pulmonary veins and all the chambers of the heart, they are well opacified. That is venous phase. So until unless specified, most of the scans are acquired in the venous phase only, because both sides of the heart and all the systems, they are opacified. Importance is that, like, if we are dealing with a highly vascular mass or a or pulmonary AVM, for example, so in that case, we need to take an arterial phase to show that yes, this nodule that we are looking at, it is getting supply from the pulmonary artery, and subsequently in venous phase, the vein is getting opacified from it. So that is very important. And also in cases of hemoptysis, you want to see that what is the vessel that is hypertrophied, is there any vessel, any aneurysm that is the cause. So in that case, we do bronchial angiography. If there is a Rasmussen aneurysm, we have to tailor it for the pulmonary angiography. Very little difference in timing of the scan, but that will make a lot of difference in interpretation.
Next question is how to differentiate the fibrosis and atelectasis.
uh, Atelectasis, typically they correspond to one segment, because that is because of some kind of segmental obstruction. That part of the lung is getting uh, atelectasis, or minute form of collapse, you may call it. Whereas fibrosis, they do not necessarily conform to any territory, any segment or anything. They can be irregular anywhere. Usually, typically, they are thinner than atelectasis.
Okay. One question regarding the can BPM, I think it's a bronchopleural fistula be identified in CT scan.
It can be, but identifying them on the film is really difficult, because in then we might miss. It depends on the size of the fistula also. No, mostly they are very small, and we have to scroll uh, through the stacks of images on the console. Finding them on the film is really difficult.
One question you mentioned that in the CF the more findings in the upper lobe and PCD in the lower lobe. So any specific reason, because both have this impaired mucociliary clearance. So why there is differential findings on the both?
I don't know.
So I can
That
reply partly of this.
you can add this.
So although both are this mucosal clearance, the mechanism different. So in PCD, the sputum is normal. Only problem the clearance because of the ciliary problem. Wherein the in CF this sputum abnormal, mucosa is abnormal. It's very thick mucosa, and that's why then in PCD dependent area will be difficult to clear more difficult. That's why there are more findings in the different areas in the PCD. And another question in the PIBO, you mentioned that there is chronic air trapping and atelectasis is there in the PIBO. So Dr. Praveen asking how long should we be there? It's to say it's chronic. I think chronic air trapping.
Okay,
Can
there
we
is.
label the first CT or we have to repeat it CT to label the chronic air trapping?
So, in the situation of an acute viral infection, we are not going to label it as bronchiolitis obliterans. In that case, it may be just exudative bronchiolitis, but still air trapping is happening. It is only after some time, maybe once the acute viral episode has gone, then even then, if the air trapping is persistent, then we are going to call it a PIBO.
One question regarding the how to monitor the lung abscess in the CT scan.
Actually, lung abscess, they will contain air, they will be intrapulmonary. So, there is no other way than to do a CT scan to monitor them. We cannot really monitor them on ultrasound. So, and how long a large abscess will take to resolve? There is no specific generic comment on that. It varies on so many factors, the size, the host response, and everything.
There are some questions regarding MRI or yes, ultrasound in the lung. We didn't cover that. But can you reply briefly? One thing they're asking the any role of the MRI in empyema for deciding decodification?
Yes, it can be done because in plural area is one thing that is very nicely seen on MR. So it can be used as an alternative, but only the restraining the factor that hinders its use is one, logistics, availability, cost, and the second thing is that in the same setting we are not sure that we are not missing out on small nodules, centrilobular nodules, right? So those things we won't be able to pick up on one MRI scan. So it becomes like that for the pleural thickening, you are doing MRI, and to pick up nodules, you are again doing CT. That is actually not that much logistically okay.
So now one question from my side. So we frequently do the ball when bronchoscopy when pediatric pulmonologist is doing. So when you are doing ball, so we have to identify the lobe which is most affected, and you have to take ball from them. So can you explain a little bit how to identify the different lobes in the CT scan? Although you report there, but sometimes we have the image in front of us when you are doing
Yeah.
bronchoscopy. So I'm
Yes.
taking idea about the how to identify the different lobes.
Okay. So there are two ways. One is seeing the fissures. Second is tracing the bronchus. So we can trace the bronchus and see uh, how the bronchus is branching, and then identify the lobe. And the other thing is we can trace the fissures. Fissures sometimes may be seen as a thin line, white line, or more commonly they are seen as a small area which is devoid of vessels. So that is avascular area, which is seen as which is the indication of fissure. Let me just see if I can find anything. So, like here in this image, we can see this is the fissure. So, if we know that this the part which is adjacent to the heart to the right side and anterior to the major fissure, then we are dealing with right middle lobe. Anything above the level of the minor fissure will be the upper lobe, and anything posterior to this major fissure will be the lower lobe. So this is broadly how you define the lobes by fissures. And by bronchus is you'll have to trace it from the trachea, carina, and the bronchial branching to call it which lobe it is going to.
Next question, the how much ultrasound is sensitive detecting the this consolidation and collapse?
If it is a big consolidation, it is very good. If it is touching the chest wall, so what we need for ultrasound is just an acoustic window. That is, there is no air between the consolidation and my probe. So if a consolidation is reaching till the chest wall, there is no air intervening between the two. So we can just put a probe and we can see that it is consolidation. And in consolidation, we put on a color Doppler and the vessels are nicely branching, properly placed. It is consolidation. But if the vessels are crowded together, they are very closely placed, then most likely we are dealing with collapse or atelectasis. Then we can see the dynamic air bronchogram as well. If there is a dynamic air bronchogram, they're moving with respiration, branching pattern, then this is a consolidation. Their airway is patent.
Dr. Javed, what time you will have? 10:15 or 10:10?
This is a 1 hour program, but if there are some questions and you want some clarification from ma'am, you can continue. If
One
you
or
have,
two questions, one is the question from the audience. How commonly you see the radiation pneumonitis in children?
Very less. I haven't seen.
Okay. The last two questions from my side. So one is we sometimes see that this virtual bronchoscopy in the CT scan. So any utility of this virtual bronchoscopy?
Yeah, virtual bronchoscopy is useful like to show what I am seeing, to translate it to show it in a better way to you. So that is the utility. Like I will be seeing the same appearance on the CT scan because the radiologist is trained to see the lesion and make a mental picture of it. But in order to show it for better visualization, virtual CT bronchoscopy is useful because it gives almost like bronchoscopy like picture, and but the basic thing is the same, acquisition is the same, it's just a reconstruction.
Okay. So thank you all. I think there are some questions regarding this GGOs already we discussed, and we didn't cover the USG. We need a separate lecture for the ultrasound of chest. There are so many questions with a very useful utility of USG in the chest. So I can request Dr. Javid, we can have the other sessions regarding the USG of the chest.
of course, I will request Dr. Manisha to have another sessions in future regarding these modalities.
Okay, but that's all from my side, Dr. Javed.
I think we have finished today's seminar. I'm thanking Dr. Manisha for a brilliant, insightful session. And we're really grateful for your time and for sharing your expertise with us. Thank you, Dr. Manisha. Thank you so much. Thank you. Good night. Good night, everybody.
Good night.
Thank you. Thank you.
Thank you.
Thank you, ma'am.